Okay, dear Professor Lange, Felix, dear Chairman, thanks again for inviting me, and let me talk about this very interesting topic. Thanks to Dr. Henrich, I can go right to the topic of intrauterine interventions. Well, we have heard a lot about critical aortic stenosis in the neonate, but usually we pediatric cardiologists are faced with a baby and a certain situation that we have. But nevertheless, there was 9 months before this aortic stenosis was present and was developing during intrauterine life, and we have demonstrated nicely. And then at the first echo in the neonate, you can see these kinds of hearts with some sort of borderline left ventricle, some degree of endocardial fibrinostosis, mitral valve abnormalities, aortic valve abnormalities. You can see this is a very high pressure left atrium, obviously with dilated pulmonary veins. During cardiac cath, you can see all kinds of cardiac dysfunction, and the question arises whether to dilate, go biventricular, univentricular, and so on. But basically, there are at least well-established now criteria when to dilate an aortic valve in the postnatal period, although there are no standards, as we heard, but there are certain recommendations, and in a gradient, mean gradient of 40 or 50 millimeter mercury, everybody would go to the cath lab and dilate this aortic valve. And now, if this aortic valve is just present before birth, and we can see it, we can see that the disease developed, why don't go ahead and dilate this valve in utero and take care of this huge gradient? Because all these findings that we have are secondary damage to the heart and to the fetal lungs. So maybe is there a chance that we can prevent this or treat this prenatally? During the last years, when we started to treat these patients, we've definitely found out that critical aortic stenosis has many different phases before birth. Usually, of course, you have an increased pressure in the left ventricle, and this left ventricle can stand these high pressures and go until birth, and these are perfect candidates for postnatal treatment. No question about that. But many of them, they will decompensate because this left ventricle at some point gets too high, and the left ventricle will suffer from any sort of damage. Usually, it starts to dilate and gets severe systolic and diastolic dysfunction. If that happens very early on in pregnancy, probably during the first scan at end of first, beginning of second trimester, you already get a picture like this with an already very small left ventricle. I will show it like this. This is a small left ventricle, a large right ventricle. So you're stuck with hypoplastic left heart syndrome from the very beginning. There is nothing to do about that. Then, if this happens later on during pregnancy, the aortic valve is getting stenotic during the second trimester, then you end up with a situation like this. The left ventricle starts to dilate, get all this sort of endocardial fibrinostosis that involves sometimes the mitral valve apparatus and the severe systolic and diastolic dysfunction, a huge left atrium, congestion of the fetal lungs, and foramen ovale closes early, and you have all that kind of problems. And there is a subset of these fetuses. We've just seen a nice example of this. If this very high pressure LV also affects the filling of the right ventricle, then we are faced with in utero congestive heart failure, because the right ventricle that had to take over the total cardiac output cannot support this cardiac output anymore, and then you get a rise in central venous pressures, and you get massive all kinds of high drops. Very rarely it can be reversible by digoxing alone, which is an interesting case report, but usually this is a non-reversible situation, and these fetuses deteriorate within days and die in utero usually. Second situation is that the left ventricular pressure rises, and the mitral valve also has some sort of abnormalities, and mitral valve starts leaking, and then you are stuck with a severe mitral regurgitation due to aortic stenosis, and not the left ventricle blows up, but the left atrium blows up here. And you've got a closed foramen ovale again before birth, congestion of the fetal lungs, and also a very bad outcome as a neonate. That's why the idea of fetal aortic valvuloplasty came up. The very first interventions were made in the late 80s by Lindsay Allen and Michael Tynan in London, where they treated 4 patients with aortic valvuloplasty. This was at the time, there was no Novot operation available. This was a subset of fetuses with 100% mortality, and they tried these interventions with more or less, but not very good success. But then an Novot operation came up, and they stopped this sort of interventions. Then there were a few case reports, and at the beginning of the year 2000, there's at least two larger programs developed by performing fetal aortic valvuloplasties. That's how this procedure is done. You have a needle that's going percutaneous through the abdomen of the mother, amniotic cavity, down through the fetal chest, directly into the left ventricle. Usually we use 18, 19 gauge needles that fits a 3.5 to 4 millimeter standard coronary balloon. We cross the valve using this a standard wire and the coronary balloon. Do this under local or general anesthesia of the mother, and then we dilate this valve 3, 4, 5 times and pull everything out and hope that the things are fixed. That's just an video how these interventions are done. Just to explain to you, there is the spine. This is the left ventricle. You can see this endocardial fibroelastosis. Already the right ventricle, the left atrium, the right atrium. Here is already the needle that tries to enter the left ventricle. You can maybe guess we are already in the left ventricle, but once we will see in a moment that's not the case, because it's very hard to perforate this EFE once it's present, and you really have to be careful to enter the left ventricle. The needling is always done by a prenatal specialist, by an obstetrician. Those are very experienced in prenatal interventions, and they can puncture all cavities that you told them they have to go to. You just have to tell them the right angle and everything. So now we are in the left ventricle. You can see the catheter comes out directly to the aortic valve. The angle has to be perfect. Now we cross the aortic valve into the ascending aorta. Now we blow up the balloon. And after the dilation, you can see a nice anterograde flow through the aortic arch. And of course, what we always want to see is some degree of aortic regurgitation. The more, the better it is, because then you see you have really done something to the aortic valve. Come back to this a little bit later. Now I want to give you some example of these 4 different kinds of aortic stenosis. This was a fetus that we got referred for aortic valve dilation because there was aortic stenosis found by the obstetrician 3 meters per second across the aortic valve at 21 weeks gestation. We said, okay, let's take a look at this, but you can see the heart is of normal size. This is the left ventricle, it's pumping nicely. Of course, there's some increased echogenicity, but the flap of the foramen ovale is in the left atrium, so you have normal right to left shunting, good squeezing left ventricle. Some aortic stenosis will say, okay, let's wait and see. Maybe this will reach term without any problems. Let's dilate it postnatally. This fetus was some degree of mitral regurgitation as well. This fetus come back 4 weeks later, and this is the progression within 4 weeks. It's easy to miss this kind of defect if you just do the 4-chamber view, do a routine screening, of course. And 4 weeks later, you get this massive dilation of this left atrium. Still a good squeezing left ventricle, but because it decompresses into the left atrium. The foramen ovale now was completely closed. There was no shunt at all because the left atrial pressure had risen a lot, and there was really congestion of the fetal lungs. This was at 24 weeks gestation. And if you just might guess how the further interuterine course would be, there's still at least 4 months to go on with this sort of situation, which is definitely not associated with a good prognosis. So we decided to do this intervention and to dilate the aortic valve. And just 6 weeks after the intervention, we get this sort of picture. The left atrium was decompressed, came back to normal size. The left ventricle still very hypertrophic. The gradient increased again from this 2.5 meters per second up to almost 4 meters per second at term, but the baby was delivered normally. The foramen ovale, by the way, opened up spontaneously again. Again, you have right to left shunting after this intervention. The baby was born in Munich, dilated there, is now 6 years of age, still without any other intervention, and had 35 millimeter gradient across the aortic valve and almost no mitral regurgitation, interestingly. So this was quite a successful intervention. Here you have an example of a dilated left ventricle with endocardial fibrinostosis, as we have seen this before. Dilation of the aortic valve resulted in a smaller size of the left ventricle, so we don't want to grow this ventricle, but we want to make it smaller. It was decompressed, had some better performance. This fetus as well had severe right ventricular dysfunction as well, so we not only have mitral regurgitation, but also tricuspid regurgitation, and you can see this large amount of ascites, and this was at the time of intervention when we tried to dilate the aortic valve. Here's the aortic valve, this is the ascites, so this fetus was in severe congestive heart failure as well. Altogether, we had 6 fetuses with this situation with severe hydrops and congestive heart failure. They were all more or less some desperate cases. 2 of them were very bad. They died despite a successful intervention. So we managed to cross the aortic valve, and all 6 of these fetuses, 2 died in utero because the heart failure persisted and we couldn't get it out of heart failure. But in all the other 4, the hydrops resolved between 18 and 35 days, and those 4 fetuses survived and are biventricular now. This was another interesting case that was referred at 22 weeks gestation. Again, the obstetrician noted some mild degree of mitral regurgitation and some aortic stenosis. Again, at 22 weeks, we said this patient is fine, is doing well. We measured 3.45 meters per second, again at 22 weeks, which is a very high left ventricular pressure, but the left ventricle was doing fine. It was right to left shunting, so we said, no, we will wait and see what will happen to these fetuses. We saw them every 2 weeks, but only 4 weeks later, we got this picture. The left ventricle decompensated, it blew up. We had enormous amount increase in total heart size, got the signs of endocardial fibrinostosis, and as we've seen before, the RV, right ventricle, was filling nicely, but there was almost no more filling of the left ventricle. Again, this was at 27 weeks, there's almost 4 months more to go. This left ventricle won't grow, will not grow anymore because it's not filling at all, and it will end up with for sure with a just borderline left ventricle with some more or less degree of severe left ventricular damage. So just to show you, this was the ventricle at the time of intervention, and you can see this ventricle isn't doing anything anymore. It's just a little bit contraction at the septum, but nothing more for that. So here's the needle again. I'm going into the left ventricle, crossing the aortic valve and dilating it, as you can see. Now we're in the left ventricle. You can see this. What happened after the intervention, just 3 weeks later, this left ventricle came back to absolutely normal size. The contraction got much better, and in color Doppler you can also see a very nice filling now of the left ventricle again. So this baby went on to term without any major problems, but the velocity increased again across the aortic valve of almost 4 meters per second, but has a nice tricuspid valve, was dilated postnatally in this so far with a residual gradient of about 30 millimeter of mercury. But definitely the primary picture at 7 weeks with this dilated ventricle would have predicted a borderline outcome at least. And then these are those cases that show up at the first echo already with some mild degree of hypoplasia with EFE, and this mild degree of hypoplasia gets more severe within a few weeks. Within 4 weeks, you have this classical picture of hypoplastic left heart syndrome. And in these cases, we have learned that the same experience that Boston has made. It's absolutely impossible. You can dilate these aortic valves, it's no problem. You can cross the aortic valves, it's not a big deal in problems. You open up the aortic valve, but you won't change anything from the natural history. These ventricles will not fill, will still become smaller and smaller, and you can prevent this hypoplastic left heart. So the size of the left ventricle definitely is one important criteria. The selection criteria that we use right now, of course, we want to have the critical aortic stenosis as a dominant lesion, and we still want to have a normal size or dilated left ventricle. We had Z-scores of -2, but in late gestation, it's dependent on gestational age, the size of the ventricle. Boston has now a Z-score of 0 as the lower limit. Z-score, it's a long axis from the apex to the mitral valve. Of course, we want to have this retrograde flow in the aortic arch as a size that this is a ductal-dependent systemic circulation. We want to have this left to right shunt across the foramen ovale. Most of them have monophasic inflow, EFE, plus minus non-immune hydrops. And if these criteria are present, retrograde flow, left to right shunt, and this EFE, it has been shown by the Boston group in a large series that they had a 100% probability of having a univentricular circulation after birth. To our results, we have dilated now, we have performed 43 fetal aortic valve dilations now in the last, in altogether 40 fetuses, which means in 3 fetuses we have repeated this aortic valve dilation 1 or 2 weeks later. Especially in the beginning, it was very difficult to have 100% technical success. So in all 40 fetuses, we were 32 technical successes, but the last 20 procedures, we had 100% success rate. We had 4 intrauterine deaths, so that leaves us with 28 live-born and successfully dilated fetuses with critical aortic stenosis. And overall, 22 of these were primarily managed to get a biventricular outcome. This is almost 80%, which would be a very nice and high number, but I come back to this in a moment. But then you're stuck with this a completely new set of patients. You have a neonate with critical aortic stenosis, some mitral valve and aortic valve abnormality, and you have to make the decision either biventricular or univentricular. And this is, as we have heard, a very difficult decision. Not all patients were treated in our institution, but we had these patients were treated in 9 different institutions in 5 different countries, because we got many referrals from outside, and the decision was always made by the team where the baby was delivered. If biventricular, they went on to an aortic valve dilation, and if that doesn't succeed, further on to surgery, either to a Roscoe aortic valvotomy surgically, or they went on to a Norwood operation. Usually it's a very tough decision, because once you decide you go biventricular and dilate the aortic valve, it's almost impossible to go back to a Norwood operation. So those 22 children, 80% were treated towards biventricular circulation. In 2 of them, this was not successful, and they had to be converted to a univentricular circulation. 1 of them died. So there were 20 more left with a biventricular circulation, but 4 of these died in the neonatal or infant period. Not all due to this aortic valve stenosis, but due to other problems at cath and necrotizing enterocolitis. So what we were left on with survival at least to 1 year were 16 cases, or a survival of or a biventricular success rate of 57%. What happened to these 16 neonates? The follow-up now is 37 months. As you can see, 7 of these 16 cases only needed an aortic balloon dilation alone. It's not 100% actual, because I've heard here only one of these 7 got a surgical valvotomy here in Berlin by Dr. Fotiades just recently, I think last week or so, at the age of 5 months. So only 6 of 16 so far, and the others, they all had a neonatal or early Ross-Conner operation. 2 of these needed a mitral valve replacement additionally later on. The procedure is not without any risks, of course, and just want to show you the complication that's about 1/3 of these fetuses. So once you enter the left ventricle, as we did it right here, a few minutes later, usually, or seconds later, you get severe bradycardia, which is always a problem, because then you cannot proceed with this procedure, and in many of these instances you get very rapid thrombus formation in the left ventricle. Now the left ventricle is filled out with the thrombus and the heart is almost stopped, so we go back and puncture the left ventricle again with a very thin needle and give epinephrine intracardially, which is successful in most of these cases. Usually within seconds later the heart rate and pressure comes up, but now you're stuck with this huge thrombus in the left ventricle, so you have no more sight and you can repeat the procedure. So you have to wait for a couple of days. This thrombus dissolves within a few days, usually without any treatment, and about 1 week later we repeated this procedure. Now we are back in the left ventricle with the needle crossing the aortic valve. You can see some residual thrombus still in the LV, just to make it a little bit shorter. Now we've crossed the aortic. You can see the balloon in the aortic valve with the aortic regurgitation, dilated the valve a couple of times and then pulled everything back out. Now the aortic valve is moving a little bit better, and you can see this flow through the aortic valve with some degree of aortic regurgitation. This is the same case. We did this intervention about 29 weeks. This was the left ventricle at the time, short before intervention. This was the left ventricle at birth, then after postnatal dilation as well. Still we couldn't, the gradient was only 15 to 20 millimeters of mercury due to this very bad left ventricular function. Dilation was absolutely unsuccessful. It was a 4 millimeter aortic valve, so this went on to a neonatal Ross-Conner surgery, and this was the echo 2 years after the Ross-Conner surgery and the cardiac cath. You can see now nice, at least systolic function, but some degree of the aortic root, of course, already. Then the other complication is pericardial effusion. When you pull out the system, as you've seen right now, you can always see for the next few heartbeats some flow out of the heart into the pericardium, which leaves usually a pericardial effusion of 2 to 3 millimeters that then stops. Usually we had to drain a pericardial effusion just once, and we had never a severe tamponade so far. And the other one is aortic regurgitation. So this here is the left ventricle. Blue is the flow across the aortic valve before the intervention, and right after the intervention you can see this in red, severe aortic regurgitation. It's almost an absent aortic valve that we have created here because we overdilate here. And it's really fascinating to see that within a few weeks this aortic regurgitation is completely gone at all. So none of our children had any significant aortic regurgitation at birth, and it was the same observation that they had in Boston. They've dilated now a little bit more than 100 patients prenatally. So before birth, the aortic valve has the potential for remodeling and for decreasing the degree of regurgitation at all. So aortic regurgitation before birth seems not to be a problem at all. The long-term follow-up now, 8 patients we are following now for 2.5 to 7.5 years, because this is the real interesting thing. 7 of 8 had a Roscono operation, a median age of 16 days. 2 needed a mitral valve replacement at 8 and 16 months respectively. 1 a permanent pacemaker due to AV block. 1 only was left with a neonatal balloon alone so far. Systolic function was good, but all had some degree of diastolic dysfunction, but all had normal pulmonary pressures, except 1 that had a mean PA pressure of 24 at the age of 3 years. So in summary, in really selected fetuses with critical aortic stenosis, you can improve hemodynamics with a successful dilation. Definitely you can reverse heart failure, hydrops, and mitral regurgitation that we have seen, and you can save the LV for a biventricular repair in up to 2/3 of patients, but really in only selected fetuses. I think this is the most important word here. And the fetal aortic valvuloplasty, definitely, we had a very long learning curve until we got the right technique, the right material, the right management of complication, but the most important thing is the proper patient selection. It doesn't make sense to dilate the aortic valve in patients that have no chance to get a biventricular repair, and this is, I think, the biggest challenge. So we have turned down a lot of referrals because we were sure that these were not no good candidates for dilation so far. But you need a high success rate and a low mortality, of course. You need to be experienced in the management of all sorts of complications that can occur, and complications are quite frequent. And you should be experienced in perinatal and neonatal management. And the delivery is also very important. Delivery should really be at the center that's very experienced in neonatal intensive care, interventional cath, and also in pediatric cardiac surgery, doing aortic valvotomies or neonatal Rosconos. Because the prenatal dilation is just one step in the management of a very critical disease, and this is not cured by a fetal intervention, but it's just the first step to improve outcome later on. But all these children need, of course, neonatal interventions, neonatal surgery, and further follow-up. Thank you for your attention.